حب قلبي حب خير رسل ربي من به أبصرت دربي يا شفيع.
Directions and what are the relations of abdominal organs to peritoneum. Now we go back and continue on the GI tract. You remember we speak about the GI or the alimentary canal in the abdomen. You have to remember it's formed of four main parts. A very tiny small part of the esophagus, which is around 1.2 centimeters. This is we refer to it as the abdominal esophagus. Okay. So there is a small part of esophagus that will enter usually at the level of T11 into the stomach. After the stomach, we have the three parts of the small intestine. Those are, what are the three divisions of small intestine? Duodenum, jejunum, and ileum. Then we have the large intestine, and it is subdivided into cecum and appendix, ascending colon, transverse, descending sigmoid, rectum, and anal canal. Okay. Speaking about the esophagus, it enters through the esophageal opening in the diaphragm, which is located at the level of T10. It will pass around 1 centimeter before it entering the stomach, at which we call it the cardial orifice. And this cardial orifice is usually located at the level of T11. Okay, at the level of T11. As it passes within the abdominal cavity, with this 1.2 centimeters, is it located intra or retroperitoneal? And I need explanation. Is it intra or retro? And if it is intra, why? If it's retro, is it primary or secondary? Once it enters into the this is the stomach, it's a J, like the letter J, and here is the esophagus, the one in blue and yellow. As it enters into the stomach, this area where the esophagus or the esophageal opening into the stomach, we call it the cardial orifice. Orifice means opening. And this area in green, the small area here, which is surrounding the cardial orifice, we refer to it as the cardia of the stomach. That's why we call it cardial orifice. At the cardial orifice now, the esophagus will have something, we name it, we call it physiologic sphincter, which is the lower esophageal sphincter. So you remember the story of upper esophageal sphincter? We said it's physiologic, not anatomy. So there is a function of a sphincter, but it's not built in within the wall of the esophagus. This function comes from a muscle of the pharynx, clicopharyngeus muscle. So we have a function, physiologic sphincter. This is the upper esophageal sphincter, and we need it to prevent regurgitation of food from esophagus into the pharynx and oral cavity. The same here, when the esophagus enters into the stomach, we need another sphincter here to prevent the regurgitation or returning back of food from the stomach back into the esophagus. So there is a function of sphincter, but it's not built in. So there is no thickening in the muscularis externa layer, okay, of the gastrointestinal tract, which indicates there is no anatomic sphincter, but there is a physiologic sphincter. This function comes from where? Which muscle contributes here? Which muscle you expect will be in this region that will contribute to closure of the esophagus? So as you know, from the respiratory system, the function of respiration, when the air enters, it's by the contraction of the diaphragm. As the diaphragm contracts, it will pressuring the abdominal organs. It's located here. As it's pressuring, okay, the abdominal organs downward, it's increasing the air pressure in the abdominal cavity, because it's reducing the size of the abdominal cavity on the expense of the thoracic cavity. Once the diaphragm contracts, the thoracic cavity will expand, the lungs will expand, the air will enter. This is the negative pressure, okay? The negative pressure respiration, okay? As it's contract also, in the same time, it will reduce the size of the abdominal cavity, increasing the pressure there. So once you have expiration, the diaphragm will contract, reducing the size of the abdominal cavity. It will squeeze on the stomach, increasing the pressure of the abdominal cavity. So very easily the food can regurgitate back into the esophagus. So how to prevent this? So the diaphragm itself, as it's located in its structure, it will surround, as you know, the esophageal opening, as I told you. You have an esophageal opening in the diaphragm. So as the diaphragm contracts, it will also close the esophagus, forming the lower esophageal sphincter. By this, the power that increases the abdominal pressure will be equal to the power that closes the esophagus. This power comes, or this force comes from the contraction of the diaphragm. If there was another muscle weaker than the diaphragm, it will not be able to withstand the force of the diaphragm. This is more physiology. You will study it in physiology. However, so the function here is physiologic. Where does it come from? From the diaphragm itself. Okay? From the diaphragm, the muscular diaphragm. So the muscle of the diaphragm forming an esophageal, lower esophageal sphincter. Exactly, it's the right crus of the diaphragm. The most important part is the stomach now. In the abdominal cavity, you have to read your text for more detailed anatomy. Stomach is an intraperitoneal structure. We all agree on that. And the peritoneal attachment to the stomach, we call them omentum. Greater omentum and lesser omentum. The stomach is divided into four main parts. This small area, which we call it the cardia, where the esophagus opening, okay? At the cardiac orifice, there is the topmost dome-shaped structure. This is dilated dome-shaped structure. We call it the fundus, and we distinguish it by a horizontal plane from the cardiac orifice. So if you put a horizontal plane like this, draw a line from the beginning of cardiac orifice all the way, all upper part here will be the fundus. While the part below the fundus here, the main part will be the body of the stomach, which is the largest in part, okay? The body of the stomach. So we have a cardiac, a fundus, dome shape, the body, the main part. After the body you have the pylorus, okay? The pylorus is the area where the chyme is digested and starts to outflow into the duodenum. Pylorus is Greek word which means the guard, the gate guard, okay? Haris al-Bawabi, or the gatekeeper. Because here, if you look carefully, the pylorus is funnel shaped. It starts wide and then narrow again. So the first part of the pylorus, we refer to it as the antrum. Antrum means entrance. The entrance into the pylorus. Okay? So the pyloric antrum, and this area of the pyloric antrum is characterized by having so many enteroendocrine cells, the G cells, which secrete a hormone, gastrin, which is responsible for growth of the gastric glands. As the gastric glands grow, you will have more parietal cells, okay, and more chief cells. So you will have more HCl. Yes. So during old ages, when they used to thought that peptic ulcer, for example, is the cause by increase in HCl secretion, they used to do something called gastrotomy, if you heard of it. So they cut part of the stomach. They used to cut the antrum. By this, they will reduce the number of G cells to a significant level. So there will be no growth in the gastric glands, and this will reduce the secretion of HCl. Okay? So this is a procedure used by surgeons to treat the peptic ulcer before discovering that it was caused by bacterial, okay, infection, Helicobacter. So this is the pyloric antrum. After you get into the antrum, into the entrance, the pylorus is funnel shaped. It starts to narrow more and more into a canal. So we call it the pyloric canal. Okay? Remember, all of this is the pylorus. You have the antrum, then you have the pyloric canal. It's narrowing to become what at the end? The duodenum. The pyloric canal ends here, where it's narrowing to become the duodenum. At this area here, the pyloric orifice, where the pyloric canal opens into the duodenum, the inner circular layer of muscularis externa. So you know from the yesterday that in GI we have mucosa, submucosa, muscularis externa, adventitia or serosa. In the muscularis externa, في outer longitudinal or inner circular. The inner circular layer becomes very thick, 3 times thick as the usual. Once it's very thick, so that when it's contract, it does not just narrow the opening here, like in other parts of intestine, it's completely closed. So this now we will call it the pyloric sphincter. And this pyloric sphincter now is anatomic or physiologic? It's both. Anatomic because it's built in and there is a function of sphincter. So when you say anatomic, by default you mean there is a function, physiology. Okay? So this is an anatomic sphincter. Yes, the pyloric sphincter is an anatomic sphincter, which means there is a structure for a sphincter and there is a function of a sphincter. Okay? So again, cardia, fundus, body, pylorus. The guard of the gate, it's subdivided into antrum, madkhal, canal, and sphincter, pyloric sphincter. Okay? After the pyloric sphincter, we will get into the small intestine. Okay? Now, something very important also here to distinguish. You have two curvatures on the stomach. We know them already. A smaller one located on towards the right side of the stomach, and we call it the lesser curvature, and the greater one, larger one, we call it the greater curvature. It's on the left side of the stomach. Now, on the lesser curvature itself, how to distinguish the end of the body and the start of the pylorus? You will see an angulation, a notch, okay? A sharp depression on the stomach. This is which we call it the angular, angle, notch, the notching, depression, okay? Notch means depression. So angular in sujur and sujura angularis in Latin, in English angular and sujur, or more correctly angular notch in English. Okay? So the same meaning. Once you see this sharp edge, okay, this sharp edge, it indicates usually what? The end of the body and the start of the pylorus. So it's called angular in sujur or in sujura angularis. It indicates the junction between the body and the pylorus of the stomach. Okay? Muscular coat of the stomach. So if you remember, I told you one of the modifications when we speak about the histology of the stomach, we have muscularis externa. It's inner circular, outer longitudinal. In the case of the stomach, we have an additional, more innermost layer. So deeper to the circular layer, there is an oblique layer. Okay, so there is an inner oblique layer. In the middle will be the circular layer. The outer is longitudinal layer. So the muscularis externa in the stomach is 3 layers. Okay, except one region. There is one region in the stomach. There is no oblique layer. This is your homework if you want to expand on that. Okay, so 3 layers coating what? The wall of the stomach of muscularis externa, oblique, circular, and longitudinal. Why 3 layers? We said that this is a modification in the histology, in the area of the stomach, because of the continuous, okay, and so much exceeding the limits, expansion and collapsing of the stomach. So as the stomach expands too much, if there is only 2 layers, there is a chance or a greater possibility of tearing in the wall. So to avoid this, in addition to the circular and longitudinal, I add an oblique layer. So you close all directions of the stomach, obliquely, horizontally, and vertically. Okay? Small intestine, again, you have to read your text for more details. However, they are subdivided into the duodenum, jejunum, and ileum. Duodenum is Latin for 12. And we said it's around length of duodenum in each individual body is as long as the breadth of 12 fingers. Okay? That's why we call it the duodenum. Duodenum length is around 25 to 30 centimeters. It is intra or retroperitoneal. First 2 centimeters are intra-hepatoduodenum, then so most of it, so in general, when we speak in general, it is a retroperitoneal. Is it primary or secondary? Secondary retroperitoneal structure. So remember, you have 4 primary retroperitoneal structures in the abdominal cavity, and you have another 4 secondary retroperitoneal structures. So in general, you have 8 structures located behind the peritoneum in the abdominal cavity. Duodenum is 25 to 30 centimeters, very short. Okay. After that, we will have jejunum. It's another Latin word which means empty. And because when you dissect the cadaver and look to the intestine, you will see Part of the small intestine located mainly in the upper left quadrant here. If you divide the abdominal body or abdominal wall or abdominal cavity into 4 quadrants by a vertical mid-sagittal plane and a plane passing through the umbilicus, you will have 4 quadrants. In the upper left quadrant, you will find mainly the jejunum, okay? And it is usually empty inside. There is no chyme if you look inside, okay? If you move continuously to the lower right quadrant now of the abdominal cavity, you will find the most twisted and longest part. It is the ileum. Ileum means twisted because it's the most twisted and it's the longest part of the small intestine. Jejunum is around 1 meter in length, approximately. Ileum is 2 meters, okay? So you have around 3.3 or 3.5 meters for the whole small intestine length, okay? Jejunum and ileum are intra-retro or what? They are intraperitoneal structures. Jejunum intraperitoneal, ileum is an intraperitoneal structure. Starting with the duodenum, this is small structure. You see the C-shaped structure curving around the head of the pancreas. So the pancreas is in the concavity of duodenum. Duodenum is retroperitoneal. So the pancreas here is, if this structure is retroperitoneal, this should be retroperitoneal. Okay, so the pancreas is the other secondary retroperitoneal structure. As the duodenum curving around the head of the pancreas in a C-shaped structure, it will be subdivided into 4 main parts. The superior part at the level of L1, then there we call it the second part of duodenum or the descending nasal part from L2, L3. Then we have another horizontal part anterior to L3. Then right to the vertebra you have the ascending part which is ascends up to the level of L2 to enter the peritoneum again. So we have a first, second, third and fourth part of duodenum. Okay, the first is the superior, the second is the descending, the third is the horizontal, the fourth is ascending. After it ascends and enters into peritoneum here, it will form a flexure, ba'jil. This is which we call it the ligament of Treitz, because here you will have the peritoneum curving around up. So here it enters into the peritoneum. So this part after this curve will be the jejunum. Okay? So here the duodenum will end and here the jejunum will start inside the peritoneum. So this curve, because of the presence of peritoneum there, okay? This part of peritoneum we refer to it as ligament of Treitz, or we call it the suspensory ligament of duodenum, if you want to look for that. However, the most important of these 4 parts of duodenum is the second part, the descending part. Why? Because of opening of the accessory digestive organ ducts there. Gallbladder, pancreas, okay? If you know them, they open there in the second part of the duodenum. If you look carefully to them, in the liver you will have the production of bile, and in the gallbladder you will have the storage of bile. So when you have a lipid-rich meal, okay, junk food, okay, for example, so you need this bile to help in digestion and absorption of fat. Okay, so the bile will be secreted through a duct system. We will study it tomorrow. And this duct system will descend down as a common bile duct, we call it. It descends from behind the pancreas, as you see. Then it will enter into the head of the pancreas from behind. It penetrates the pancreas and gets inside to join the pancreatic duct. Once the main pancreatic duct, along with the common bile duct joined together, they will become a very wide, large duct. When the duct is very wide, we call it ampulla, like the ampulla of the drug. When you, if you have an injectional drug, you will have it in a glass bottle. We call it ampulla because it's dilated bottle. So ampulla means a dilated duct. This ampulla was discovered by Abraham Vater, a German anatomist, so we call it ampulla of Vater. Okay? Or in American language, ampulla of Vater. Okay? So this is the ampulla of Vater. The ampulla of water now, where does it open? As you see in the second part of duodenum. Okay? As it opens, ampulla of water, which contains the bile and the pancreatic secretion, as it opens into the second part of duodenum, it will form a small projection, finger-like projection in the wall of duodenum. So this projection we would call it major duodenal papilla. Remember, papilla is a finger-like projection. So ampulla of water opens into the major duodenal papilla. If you look carefully above, you will see a smaller papilla. This is the minor duodenal papilla, and it indicates the opening of another pancreatic duct, a small one here, just this one, till here. This is, we call it accessory pancreatic duct, okay, or duct of Santorini. So this is the accessory pancreatic duct. It drains, as you see, upper part of the head of the pancreas, while all of this one here is the main pancreatic duct. Okay, so you have two pancreatic ducts opening into the duodenum. The accessory opens superiorly through minor duodenal papilla. The main one of pancreatic duct joins the bile duct into a larger duct, we call it ampulla of water, and they open into the major duodenal papilla of the second part of duodenum. So duodenum is important, second part of duodenum is important because it contains the openings, okay, for ampulla of water and accessory pancreatic duct. Jejunum and ileum, not much to speak about them. We already covered them. I told you, if you divide the abdominal cavity into quadrants, or in a oblique way like this, the upper left diamond هو الجejunum, the lower right is the ileum. Now, how to distinguish them in a cadaver or in a gross morphology? First, the lumen. If you look to the lumen, it's much wider in the jejunum than in the ileum. Okay, so lumen of jejunum is wider. Okay, that makes sense. As the intestine moves down, it will become more narrow. Plicae circularis. The plicae circularis are the folds. Okay, these are folds in the small intestine. You studied them in histology to increase the surface area of intestine. By increasing the surface area of intestine, we increase the number of absorptive epithelial cells, so more function of absorption. We call them plicae circularis. Plicae, Latin for folds, circularis, Latin for circular. So these are circular folds in the wall of intestine. In the jejunum, they are much larger and more numerous. If you see here, too many. While here you see they are much shorter and sparse. قليلات جدا. Okay? Plicae circularis. Because the function of absorption here become reduced so much. إذن jejunum, lumen wider. Plicae circularis are larger and more numerous, okay, than the ileum. The second thing, the mesenteric arcades. These are arcades. Arcades means small arcs. Because arterial blood supply to the small intestine, as the mesenteric arteries pass, they will start to give so many branches that join together to form arterial arches, arcades, okay. If you look carefully in the jejunum, these arcades are very few, only one line. One or two rows of arcades. While here you will see 3 or 4 lines of arcades, okay, in the ileum. So more arterial blood supply, more arterial arcades in the ileum rather than in the jejunum. Fat deposition, where you expect the fat will be more deposited? In the jejunum or in the ileum? In the ileum, actually, downward. Okay, so more fat deposition in the ileum. So if you look to the fat across the mesentery, which passes from posterior abdominal wall to the jejunum, you will see the fat only located near the root of the mesentery. But close to the intestinal wall of jejunum, there is no fat. If you move down, you will start to see the fat expanding up until it reaches the intestinal wall. As you see that, the fat is start to be deposited on the wall of the intestine of the ileum. This is the ileum. Okay, so more fat deposition in the ileum. Now, something lastly is the Bayer's patches of Bayer. What does Bayer's patches? Those. Yes, so they are lymphatic nodules, okay? Aggregation of lymphatic nodules helping in immune response and protection. They are located only in the ileum, only in the ileum. Where in the ileum? In which histologic layer? Stage. صح ولا غلط؟ مش مشكلة. Nobody knows. They are actually expand into the submucosa, but they start in lamina propria of mucosa. But as they enlarge, depends on the presence of infection or not, they can get even into the submucosa. So you will find some of them in the submucosa actually. But they start usually formed in lamina propria of the mucosa. Large intestine هذا كله حكيناه وبتعرفوه بس بتعرفوا السيكم وابندكس انترا والريتروبريتونيوم. Appendix has a appendix, so it's intraperitoneum. What about the cecum? Go back to the previous lecture, okay? When you look to large intestine, how to distinguish it from small intestine? 4 main features. 4 شغلات. أول شيء بتشوفوا الفرق إنه بلش large intestine يعمل ساكيولز، تكيسات. These things, these structures are not present in the small intestine. These sacculations are actually because of what? We call them hostra. Hostrum is the single, okay? Or saccules, saccule is the single. Why these saccules are there? Because the length of large intestine is around 1.5 meters. However, the longitudinal muscle layer of muscularis externa in the large intestine is only around 1 meter. So it's shorter. This muscle here, longitudinal muscle layer, in large intestine, the longitudinal layer of muscularis externa, you know that external muscularis layer في wall of intestine, inner circular, outer longitudinal. Now in the large intestine, the outer longitudinal layer will not continue all over the wall. Instead, the muscle fibers will start to aggregate in 3 bundles. So if you look, you don't see here longitudinal layer, you see them only in this row. This is another one, and there should be another one inferiorly. So these, you will have 3 rows of longitudinal muscle bundles, okay? So they are not covering all around the large intestine, longitudinal layer of muscularis externa. It's only the fibers aggregate, تبدأ تتجمع in 3 areas only, forming a longitudinal muscle bundles. These muscle bundles, we call them tinea coli. Okay? Tinea coli is what? It is the longitudinal layer of muscularis externa, where the fibers aggregated into 3 bands only. Okay? This tinea coli now, longitudinal layer, is 1 meter in length, almost, around 1 meter. With large intestine is like 1.5 meter. Same as in the keratin. إذا سمعتوا بالبرداي الكيرتين. الكيرتين إذا كان طولها 1.5 متر والرود تاعها متر، فأنت بتكون فاتحها لما بدك تفتحها الآن بتكون مسكرها، لما بدك تفتحها بدك ترجعها من 1.5 متر لغاية متر على الرود. شو بصير بالكيرتين؟ لما بتفتحوها it folds، صح؟ لما بتفتحوا البرداي شو بصير فيها؟ تبدأ تلف على بعضها. واي؟ لأنك أنت بدل ما أنت فارقها على طول 1.5 متر رجعها على متر، فمسافة القضيب بتاعها صارت متر اللي ماشي عليها الكيرتين بدل ما تكون 1.5 متر. The same thing here. As you're gonna put this tinea coli over all the 1.5 meter of a large intestine, you need to saculate, to fold the large intestine so that it fits the whole tinea coli. So why it's there? Because of the tensing of large intestine saccules. They are formed because of tinea coli, longitudinal muscular external layer is shorter than the actual length of the large intestine. Okay? That's why the tinea coli. Tinea coli then is the 3 bands of muscles that extend from the base of the appendix. So at the appendix there are no tinea coli muscle. The appendix does not have tinea coli, okay? While they start from the base of the cecum all the way until the rectum, okay? Until the rectum. So also the rectum, in the rectum there is no tinea coli. The tinea coli here at the base of the sigmoid colon At the start of the rectum, the fibers will start expand again around the rectum. Okay? So they don't form the tinea coli. If you look carefully here, these are the sacules, and these yellow structures are fatty deposits on large intestine. You see this line of smooth muscle here. This is one band of tinea coli. Okay? This is a band of tinea coli. Remember 3 bands. How they are located? If you look in a lateral view, you see this is the transverse, for example, mesocolon. Okay? The transverse colon. In the transverse colon, one of the bands will aggregate here at the attachment of transverse mesocolon with the transverse colon. So you will find one band in this region. We will call it mesocolic band, okay, of tinea coli. It's mesocolic because it's in the attachment of the mesocolon. The other band will be located here at the attachment of greater omentum with the transverse colon. So this will be named the omental band of tinea coli. So we have one, the aggregation of longitudinal muscles, they will aggregate here at the mesocolic part, here at the omental part. The third part will be here, free, in upper anterior superior. So we have a posterior, anterior inferior, and anterior superior band here. It does not have any relation to attachment of peritoneum. So we will call it tinea libera. Libera is Latin for free, the free band of tinea coli, because it is not related to peritoneum. So 3 bands, mesocolic band, omental band, and tinea libera band of tinea coli. So when we speak about large intestine, how to distinguish it? You will find rostra or sacules. These are formed because you will find smooth muscle bands. We call them tinea coli. What else? You will see so many deposits of fat, okay, in the form of small appendices, إضافي, appendages, okay. So we call them omental, or these are ones, okay, omental or epiploid appendices, okay. And it can be distinguished by the flexures. Flexures means the curvatures here. Right colic flexure between ascending and transverse colon. The left colic flexure between transverse and descending colon. Few clinical notes. Peritonitis. What is peritonitis? Inflammation of peritoneum. If it's there, the fluid in the peritoneal cavity will start to accumulate, okay, much more, and the abdominal cavity will enlarge. So this fluid inside the peritoneal cavity accumulates because of infection of peritonitis. We will name it ascites. So ascites, when there is a distension in the peritoneal cavity by abnormal fluid. This abnormal fluid will be the ascites, okay? Peritonitis and ascites. The treatment, draining the abdominal cavity by inserting a needle in the midline, through which we call it linea alba or white line. It's a fibrous area where there is no blood supply or innervation, so you don't get afraid in the middle of the abdomen. So there is no harm of any injury. You just insert a needle into the peritoneal cavity and drain it. Okay? We call it paracentesis. Paracentesis is draining the peritoneal fluid from within the peritoneal cavity. Second thing, appendicitis, inflammation of the appendix. It is because of either bacterial infection or obstruction of there because of chyme accumulation and foreign object starts to present, then the bacterial infection get in. Signs and symptoms. Symptoms of appendicitis. أول شيء البين. هذا very important. The pain, the patient will start to complain of vague pain in the peri-umbilical region. Okay, in the air perimeter. This is because the appendix is inflamed, but it is, as it's inflamed, it's irritating the visceral peritoneum, covering it. Remember, it's intraperitoneal. Visceral peritoneum innervation, we said it's autonomic innervation. So you don't feel it in its location, you feel it as a referred pain. So it's referred to around the umbilicus. So the patient starts to feel what? Pain in the pre-umbilical area. This is a referred pain because of irritating the visceral layer of peritoneum. As the appendix enlarged due to inflammation, and starts to touch the parietal peritoneum now. The parietal peritoneum is innervated by somatic innervation, by the abdominal wall innervation. So now the pain will start to transmit or to move from periumbilical, you will see it to become into the lower right quadrant at the location of the umbilicus. So now, and it will become more severe. So it will become a severe pain in the lower right quadrant due to irritation now of what? Of parietal peritoneum. So if the patient feels the pain directly, severe pain in the lower right quadrant, this indicates what? A late stage of appendicitis. It's an urgent or emergency treatment. The treatment is surgical removal, appendectomy. Okay? But be careful now. So if any patient told you he feels a vague pain around the umbilicus, you have to what? To advise him to do always what? An investigation for his appendix. Okay? Before getting into late stage. Okay? So it's a vague pain in the periumbilical region, then it moves towards the lower right quadrant, starts irritating the parietal peritoneum. When it comes to he will start to do vomiting. So the pain and the vomiting are symptoms of the patient. When he comes to the clinics directly, and fever also, you have to test for, you ask for a blood test. The blood test will show you an elevation in the number of white blood cells, leukocytosis. Leukocytosis indicates always a presence of infection, okay, or inflammation. So you have to have leukocytosis. You refer him directly to the surgery for appendectomy. In appendectomy procedure now, there are two kinds of appendectomy. There is an open appendectomy where you use a knife, you cut through the abdominal wall, you get into there, okay? Or there is nowadays the more recent one, which is laparoscopic appendectomy, where they use a laparoscopes, okay, procedure. In all the procedure, open appendectomy, you determine the area of incision as McBurney's point. Referring to Charles McBurney, McBurney described that if you draw a line from the anterior superior iliac spine, you can easily palpate the anterior superior iliac spine, into the umbilicus, you draw an oblique line, straight line, from anterior superior iliac spine to the umbilicus, the base of the appendix, because you want to remove the appendix from its, not from here, from its base, from its attachment with the cecum. So the base of the appendix will correspond to a point located 1/3 from the anterior superior iliac spine and 2/3 from the umbilicus. Now this point where you have to do your incision, which we call it McBurney's incision, okay? The McBurney's incision. So at this point you have to do the opening, which we call it McBurney's point, you do McBurney's incision. So McBurney's point, it is the point that corresponds to the base of the appendix, okay, on surface anatomy, and it's located at 1/3 from the anterior superior iliac spine and 2/3 from the umbilicus. This is for open appendectomy. What about laparoscopic appendectomy, which is a much easier procedure? So just follow with me on this two last videos and we will finish.
Removal of the appendix, called appendectomy, is performed when appendicitis is suspected. Right lower abdominal pain, fever, and elevated white blood cell count are common symptoms and signs of appendicitis, which usually occurs when a blockage develops between the appendix and the intestine. This leads to infection, swelling, and distension. If the appendix is not removed, it can lead to a life-threatening perforation or rupture. The only treatment for appendicitis is appendectomy, which is almost always performed on an emergency basis.
On emergency basis, as you
Many laparoscopic techniques require only tiny keyhole incisions or puncture wounds, which generally result in a shorter recovery period. Before your surgery, an intravenous line will be started. Appendectomies are done under general anesthesia, which will put you to sleep for the duration.
If there is a general anesthesia, what's next? Breathing tube.
A catheter may also be placed in your...
Why we inserted a breathing tube? To avoid the collapse of the tongue by geniocclusus. Okay. Why we insert a catheter into the bladder, in the urinary bladder? Because under general anesthesia, the patient will lose control on his bladder. Okay? So you need to empty the bladder each time there is a catheter and urine sac.
An uncomplicated laparoscopic appendectomy usually takes between 20 and 30 minutes.
So it's around half an hour.
Your appendix, the surgeon will
This instrument is named trocar. So we need 3 trocars. Trocar is an instrument that have a tube to be penetrating the abdominal wall inside. And through the trocar you can insert your instruments. Okay, you can insert first the camera, which will produce what? The vision. Okay, another one you will use it, for example, to inflate the abdominal cavity, because the abdominal cavity is very small and structures close to each other. You need more space. So one of them you can insert gas in the abdominal cavity, usually CO2. Okay, you pump the abdominal cavity with CO2 to make a wider space and separate the organs from each other. A third one you can use it for inserting surgical instruments. Okay. So we need always 3 trocars, so 3 openings in laparoscopic surgery. Okay? Remember this.
usually located anteriorly behind this and in the upper right and lower left quadrants of your abdomen. Carbon dioxide gas will then be pumped through the umbilical port.
So CO2 is pumped.
Contents can be viewed more easily. Next, your surgeon will insert the laparoscope through the umbilical port. Images from its camera are projected onto a video monitor in the operating room. The surgeon will carefully examine the inside of your abdomen, confirming that your appendix is red, swollen, and needs removal. At this point, your surgeon will pass surgical instruments through the other 2 ports, grasp the appendix.
This instrument now is the electrocutter. Okay? You saw it in the previous video. I'm not sure if you have the same group. So the electrocutter is you use electric current to burn, to cutter, تكوي, okay, the structure. As you burn it, you will cut it, you will avoid any infection, you disinfect, and there you will ligate the blood vessels. So there is no bleeding or hemorrhage. So 3 advantages, 3 in 1, as they say. 3 advantages, 3 advantages from using electrocautery. Okay, disinfection, cutting, and ligation at the same time.
Into a specimen bag and remove the specimen bag through one of the
Why did they insert the appendix in a specimen bag when they remove it? So he cut the appendix, you see, then he inserted into a specimen bag, into a disinfected, sterile bag. Because this infected appendix will pass through the abdominal wall. You don't want it to become in touch with the muscles of the abdominal wall. So the infection can spread. So you cover it within a sterile bag and you take it out, okay, through the trocars. Irrigation, okay, this irrigation is important to remove any remnants and to disinfect, sterilization, with normal saline usually.
damage. When the laparoscope is removed, a port valve is left in.
The last one, trocar, will lift for a few hours, for a few minutes. Why?
The keyhole incisions are closed with suture.
For release of the CO2, okay, from inside the abdominal cavity.
Conclusion of the surgery. Your breathing tube and catheter will be removed, and you will be taken to the recovery area for monitoring, where you will be given pain medication as needed. When you are
So
able
let's see a real laparoscopic removal of appendix. You want the music? So look carefully here, guys. You can see this is the appendix. This is the peritoneal covering of the appendix. This is called mesoappendix. Okay? And you see how it's transparent and shiny? This glistening appearance indicates it's covered by a transparent membrane. It is the peritoneum. Okay? This is the mesoappendix. This now instrument is the electrocutter. He will bear the mesoappendix first. So he is separating the appendix, okay, from its peritoneal attachment. This is under the laparoscopic procedure. After he cut it. So there is few bleeding, you cut again. He needs to cut here to burn it. Yes, to avoid the bleeding from within the peritoneum. Just keep cutting. So this is here the base of the appendix, in a close relation to the cecum. You see, this is the cecum. And by the way, remember, location of appendix, it's always retrocecal. So it's behind the cecum, usually. He is separated between the two layers of peritoneum, you see? This is a layer covering and returning back here. So this is the mesoappendix. Small amount of bleeding. Wherever he finds bleeding, he needs to cut her. But be careful to burn any part of the large intestine, okay, along with it. Just he's cutting the peritoneal attachment. You see this transparent membrane, this is the peritoneum. You see it here? This membrane he's cutting, this is the peritoneum. Okay? It's a transparent, smooth membrane. شفاف. This is the appendix separated. He block it, okay, with the clips or with wire. Why? Why he's inserting this wire? To prevent discharge of chyle or feces out from large intestine, okay, through the stomach. So he is blocking the opening here, as you see. He needs to block again with another one. This is another wire. This is a confirmation, or to make sure that there will be a complete blockage. They should put another one here. Whitish in this tissue always indicates avascularization. Always. This white area, patch, we call it white patch, here in surgery, it indicates there is no blood supply anymore. Okay? It's avascular region. Simply he cuts the appendix. He needs to cut it, not to cut it actually, yes. So he was burning to prevent bleeding, okay? This is the appendix, has been removed. This is the sterile sac where he will insert the appendix inside and remove it through the trocar, okay? So he will remove it now outside of the abdominal cavity. This is the area where the appendix was attached to the cecum, and I will just show you how he will remove now the camera outside of the abdominal, the trocar. This is the edge here of the trocar. Now he is inspecting if there is any bleeding. This is important. You need to prepare a few minutes always after any surgical procedure to make sure there was no bleeding. He is removing the trocars from inside the abdominal cavity. Now he is removing the camera, and that's it.